and welcome to episode 72 of the Let's Talk Thyroid podcast. I'm Annabelle Bateman and you are in for a groundbreaking treat today. I am talking with Dr. Eric Balcavage about his brand new book that he wrote with Dr. Kelly Halderman called The Thyroid Debacle. I'll let him explain exactly why it's a debacle, but if you've kind of been in the thyroid health system for a while, or perhaps it took you many years or even decades to be diagnosed, you'll have a bit of an inkling of what the thyroid debacle is. You will probably also want to listen to the previous episode I did with Dr. Balcavage, which was episode 58, all about cellular hypothyroidism. We dive into that a little bit in this interview, but you'll definitely want to re-listen to that or listen to that episode. This is one where you're going to want to probably listen to it a couple of times. Fairly chunky information, heavy. It's heavy information, but really important information to grasp, because it is all about the way thyroid hormones work, the way your body works, how we can get hypothyroid, be hypothyroid in other parts of our body, not just in our thyroid gland. And that is really important if you're suffering from hypothyroid symptoms, but don't necessarily have it coming up yet in your blood tests. So take a notepad and a pen, make some notes. I've made about 7 or 8 pages of notes as I've re-listened to this conversation. It is going to be a groundbreaking book, I believe, for the medical and the holistic health communities, both for practitioners and for patients, just in understanding the new literature, the new research, and just a really fresh perspective on thyroid health diagnosis and management. So sit back, relax, enjoy, grab a cuppa and a pen and a notebook, and I hope you find it really, really informative. Yeah, all right. Well, welcome Dr. Eric Balcavage to the Let's Talk Thyroid podcast for number 2. This is the second time you've been on my show, which I'm very grateful for. So welcome. Welcome back.
I appreciate you having me back on. It's we had a great conversation last time. We had a great conversation when you were on my podcast and we talked about your book. So I'm glad to see you got yours done and we got to talk about it. I think it's going to be we talked about on my podcast, a great resource for people, especially as they're kind of dipping their toes into the waters of this whole new thyroid world that they may get thrown into.
Yeah, absolutely. And that's really who my book is targeted at. And look, I think I can no longer say now mine's the hottest new thyroid book on the market, because your book is now the hottest new thyroid book on the market. So I'm looking forward to getting into talking all about it. I just finished reading it yesterday, and it is, talking about resources, it is a resource. To me, The Thyroid Debacle, which is the title of the book, is a resource that I'll go back and dip into and reread and take so much more from every time I would dip back into it, I think.
Yeah, I think it's one of those, I think it's going to turn out to be a book that's going to be something that's going to be, could be a resource, right? And it's something that you're probably not going to, especially that second section is a little meaty. Yep. And I did get I had a couple comments from people that didn't have thyroid issues that said, this is you get kind of deep here. I'm like, well, the people who struggle with chronic thyroid problems get deep into what's going on with their physiology. I mean, these are typically, maybe early on they don't know much, but the longer you've got thyroid issues and you're struggling with them and you're not seeing the solutions and the results you want in a medical model, you do start getting really into trying to understand thyroid physiology, what's causing hypothyroidism, what's creating this immune-driven process. So I think it could be a good resource for people to get a little deeper, see where the science is kind of headed and going, and so they can get a new perspective on what's going on. But I agree. It's a little thick, it's a little heavy at times, but I think I do an okay job trying to give some analogies, give some explanations that make it more understandable. But
yep.
You read it, and you're a person who's in this world, who lives in this world. So you're not the physician, so you might not have all of the kind of the knowledge base that I'm trying to explain in the book. But if you've got enough experiences with what you've been through, and maybe if you're picking it up and saying, "Hey, I get it," I'd start to understand it. Then I think I've done the job that we want to do.
Yeah, I would say you've got to read all of it. That's what I would say. Is when I got to the end, I was like, right now. I think it takes time when you're dealing. We might be jumping ahead a little bit, but when we're dealing with new concepts of the way that we're talking about thyroid health, thyroid physiology, what is thyroid health? It's more than thyroid. The whole picture. Your mind is constantly like, oh, okay, oh, what does that mean? And I found myself, I think I've got about 300 highlights because I was reading it on the Kindle version, so I could highlight and make notes. And I made about 300 highlights, and I'd sort of make a note, well, what about this? And then I'd read on and, oh, okay, that's so. If you do know a bit and you're reading it, probably questions come up, and then you think, oh, hold on, how does that work? And then, a few paragraphs later, you answer that question. So I think whilst there are parts of it that are quite heavy with the science, that obviously adds the complete credibility to it all. That's the whole. It's worth sticking through it and just pushing through it, because it does. I found then the dots were connected just by reading the whole thing. Yeah.
Yeah. Well, I think that makes it feel good, and we talk. Makes me feel good. I'm sure if Kelly's listening, she would say that the same thing. And we wanted it to be. Somebody asked me, like, who's the book for? And I said, well, the book is for people who are struggling with chronic hypothyroidism. So they need to understand what's different in what we're talking about, because it's kind of a different perspective and different way to look at what's going on. But I also want it to be for a clinician who picks up the book and says, I can learn from this too to help my clients. And I think Datis Karazian did that with his book. When his book came out, it was written towards the layperson, the person who's struggling with chronic hypothyroidism. But I don't know that there isn't a functional medicine practitioner
that hasn't read
who hasn't picked that book and read it at least once or twice or 3 times. Because when you go through that book, same thing. You go through Datis's book and you make a highlight and you go, let me think about that. And I do that all the time anyway with every book, right? I go through a book, I read something, I make a note, I got to go check that up. Let me look that up. Let me come back to that, because sometimes all the pieces don't come together, or as you said, your mind is going, wait a minute, let me think about stuff. But that's good. When you get a book, I think that really makes you stop and think, and not just kind of skim through it and really make you think. I think that's where you're getting the value, and I'm hoping this turns out to be a good value for everybody who purchases it.
Yeah, well, yeah. Look, I agree. And so if you're listening to this podcast, and we're going to dive into some of the highlights, I think. And I should just say that in the last episode, when you were on my show before, we talked all about cellular hypothyroidism. That was the core focus of that podcast interview. So whilst I'm sure we'll touch on that because it's core to your book, if you want to dig deeper into that, go and listen to that episode, because we really dive really deeply into cell danger response, cell protection, really the core of what cellular hypothyroidism is. So when we're talking about that, as it will come up in this discussion, go and listen to that episode if you haven't listened already, or go listen to it again, I would probably say, because there was a lot of really helpful information in that, and we don't need to go back over that. So let me just dive in and ask you, well, what is the debacle? What's the debacle?
So I think anybody who's kind of been diagnosed with hypothyroidism, been put on meds, and continues not to feel good, they're struggling, right? They're told, hey, your TSH is normal. What's wrong with you is just that you eat too much, you don't exercise enough, you're lazy, you're crazy, right? Or for the person who's struggling with what seems like chronic hypothyroid signs and symptoms, they're constipated, they got no libido, their skin's dry, their hair's falling out, they're gaining weight, they got brain fog, and they just Google search and they say, oh, this looks like a thyroid problem. And then they go to their doctor and they run one test, a TSH as a screening test, and it comes back within the lab reference range, which, by the way, isn't necessarily a health range. And the doctor just tells them you eat too much, you don't exercise enough, it's something else, but it's not related to your thyroid, because this one value, which is the screening test, indicates you don't have a thyroid condition. And people get frustrated, and then what happens, especially for the person who doesn't have a diagnosis, is they believe their physician that they eat too much, they don't exercise, even though they probably are already doing it. They start taking medications for their cholesterol that's elevated because they have a tissue hypothyroidism going on. They take antidepressants because they believe the physician who says maybe you have depression or anxiety. And they starve themselves because they think they're eating too much. And they wind up doing a whole bunch of things that actually make the condition even worse, and continue to go, on and on year after year, being told, nope, nothing to see here, nothing wrong with you. And then one day they go into the office with all the same signs and symptoms, and that TSH is done with a reflex to T4, and now TSH is finally elevated, and they go, okay, free T4 is out of range, TSH is high, you have a thyroid condition. And they're like, okay, now we can treat you. Well, wait a minute, doc. I've had these same symptoms for the last 6 years, and you told me it wasn't a thyroid problem. Now, with nothing else changed, same signs and symptoms, now that value's higher, and now I have a thyroid condition? Yep. And so it's frustrating. And for the person who's on medications, they wind up doing this game of yo-yo or whack-a-mole with their TSH level, right? And I get put on meds, I feel good for a bit, and then the honeymoon's over, and now I'm starting to I've plateaued, and they said, we'll give you more medication, and now I get more medication, and now I feel like I'm hyper. Nope, that can't be. You stay on it, and they get just up and down on different doses, different types of medications, and they still, at the end of the day, don't feel well. And the biggest reason for it is we take too limited of a view at assessing somebody's physiology. We're looking at two values, TSH and a free T4, and that's it when allopathic medicine is assessing thyroid physiology, or the physiology, thyroid physiology in the whole body. And those two values can't truly represent what's going on in all the cells and tissues of the body. And the one test that we use as the screening test is influenced by so many factors that could hide a thyroid condition for months, years, or decades. And so the medical community has hung their hat on this one test that they think is like the perfect test, and it's a disaster. It's a debacle, because we got people that are struggling. And we have, I think they talk about 8 to 10% of the population may have a thyroid condition, something like that as a max. I think the number, if you consider the fact that to have insulin resistance or high cholesterol, there's likely a tissue hypothyroid state in all of those conditions. And we've got obesity rates, overweight, I think 70% of the U.S. population, I don't know what it's like there, is overweight.
I don't think we're any better. I think we're pretty similar. Australia's pretty bad too.
If somebody's overweight and obese, guess what they have? They have a slow metabolism. Guess what helps run metabolism? Your thyroid physiology. Not necessarily at the gland, not necessarily what's in the bloodstream, but what's at the tissue level. So we're looking at one marker, maybe a second, and we're waiting until the person has all-out glandular dysfunction to do anything. Even though we know that the primary cause is immune-driven, we're waiting for the immune system to totally destroy a gland before we say, hey, there's something to see here, there's something to do here. And I think sometimes, I'm not sure, and I hate to give doctors a hard time, but we got to look at the person sitting right in front of us, right? Like, if you have signs and symptoms of hypothyroidism and one value, if you're only running two tests, you can't see what else is going on. You got to start to say, well, maybe that value is normal, but it's inappropriate for my patient. So maybe I got to do a little bit more work. But because of insurance rules and all other these guideline nonsense, people are just being told that they're lazy, they're crazy, they're nuts, they eat too much, they don't exercise, and they're getting all the blame for a condition. Instead of physicians doing a better job and saying, hey, the patient's struggling, the patient's suffering, something's wrong, we got to dig in deeper and help this person. But maybe that's what gives us space as functional medicine practitioners to really help out these people.
Yeah. Yeah, it is that part of the system, medical system, is a debacle. I find it phenomenal. I was talking to a doctor here in Australia yesterday, interviewed her for the podcast. She's over in Perth. She's got thyroid problems herself, and that's what took her then down the path of, she said, I just treated myself like I would treat any other thyroid patient. And, TSH came back normal, T4 was normal, but she had an ache in her thyroid and she kept thinking, this isn't right. That's where my thyroid is. I'm going to, and so then she ran more, the full thyroid panel with the antibodies, and there the antibodies were through the roof. And she's like, and so, I know, and I said, but I don't understand. I guess I got this from Dr. Karatsian, was why are not the antibodies the base level test? Like, why are they not? Because they show up for so many years before and because they don't think you can do anything about it. I know that's the answer, but it's just, as a patient, I just find it, I don't know, first do no harm. There's a lot of harm being done. So I agree, it is a debacle.
I think part of the reason is they don't know what to do, right?
Yeah.
And so if the only tool in the toolbox is to give you more thyroid medication, if you give thyroid medication too soon, you create hyperthyroidism to some degree and hypothyroidism because you're overwhelming the system. So they've learned their lesson that giving thyroid hormone too early or inappropriately creates problems. So I think the lesson has become, hey, let's just sit back and wait. And yes, I think most physicians would agree that it's immune driven, but it's autoimmune. We don't know what causes it, but that doesn't mean you shouldn't try and figure it out. Right. But the way the way the system's set up is that's costly, takes a lot of work. The medical community really likes one cause, one cure, right? That's what we really like as a medical community. So when you start to say, listen, you could have 10 hypothyroid patients all have thyroiditis, but for 10 different primary causes, right? Or some people may have 3 or 4 or 5 or 6 accumulative things that are driving that immune dysregulation. And so, man, that's messy. So we don't like that, right? Look at blood pressure. I mean, there's a lot of reasons that blood pressure is elevated, but do we really ever identify the reason for it? No. What do we do?
Blood pressure meds.
Blood pressure medications, and we'll give a beta blocker. Oh, that didn't work. We'll give an angiotensin 2 inhibitor. Oh, that didn't work. Now we'll give you calcium channel blocker. Oh, okay. Now you need 3. You need 3? Well, I started with the beta blocker. It worked for a while. Then I went to this one. Okay. Did we ever consider to think, why do we have high blood pressure? Right? No. So the model is just one where I think it's easier to make a diagnosis, give a pill for the diagnosis, than to try and get to root cause issues. But again, that's where we can come in and shine as functional medicine practitioners.
Yeah. And I've got to say, actually, reading this section, because your book was co-authored with Dr. Kelly Halderman, and she wrote the whole section on the allopathic model, your traditional sort of model. And I've got to say, in reading all of that, I did have a deeper appreciation for the doctor and in understanding all the different types of, well, even just within thyroid, all the different things they're trying to rule in and rule out. And even if you just look at the model that they're operating under, I thought, oh, all right, okay. I had a bit more compassion. I think it actually was helpful to go, all right, the doctors they're just doing what they've been trained to do. They're doing and so that in itself, that's the problem. And yes, you could say, well, you need to look at the person that's in front of you and all of those, those things. But it did give me a greater understanding, I think, for how that medical model is and how it works and the different ways that they're working and diagnosing. And I found that helpful, actually.
Yeah. And look, Kelly and I both came from a medical model, right? And so we were both angry with our own health issues, right, with the community. But as you get older, you soften a little bit and you realize that, overall, they're not bad people. They're not people trying to be mean or not take care of you. They're just working within the training and the guidelines. And that's why we thought that, writing this book was important, not just for if an allopathic physician picks it up and says, I didn't know some of this stuff, or I didn't even think about this stuff, or I wasn't taught this stuff, or hey, this stuff goes against our guidelines. We thought it would be great if they could pick it up, but we also wanted it for our community, the functional medicine community, who's at times practicing allopathically with just a different type of thyroid medication. Instead of really addressing root cause, we're saying, hey, if T4 doesn't work, then we'll give T3, and we wind up in the same scenario. So, for some people, just standard treatment's fine and it works, but there's a growing amount of people who it's not really working for. And I think what we discuss in the book, especially in part 2 and part 3 is, hey, if you change the way we look at our bodies and our physiology from my body is attacking myself to, hey, my cells operate in one of two states, either danger mode or low stress mode. And if I'm in danger mode, normal physiology doesn't run the way we typically would like it to run, right? The normal physiologic process gets slowed down because the primary focus isn't on having sex. The primary focus isn't on digesting food. The primary focus isn't on getting a good quality sleep. The focus is on protection and cell defense. And sometimes I think we make the assumption that everybody coming to see us with a health problem is in a state of what we call low stress or homeostasis, when almost none of them are.
Yeah. I think the way that you described in the book that thyroid health is a spectrum, just like it's a spectrum disorder, I found that really helpful, and it makes sense when you think about the example you gave before about the person that goes in with the same symptoms for year after year after year, and eventually they're diagnosed. So can you explain what that means when you're talking about thyroid on a spectrum?
Yeah, so if we look at it from the classic kind of allopathic perspective, hypothyroidism essentially starts when the gland's destroyed, greater than 90% of the thyroid gland's destroyed, and we've lost more than 90% of the function. That's when TSH goes high and free T4 goes low. So, but that's not the beginning of a problem, right? That just means that the gland is no longer can produce enough to support all the tissues. But from my 27 years in practice, plus the time looking at the literature, the thyroid gland making thyroid hormone, mostly T4, a little bit of T3, is just part of the picture. Once it's made, it's got to get into the bloodstream, and it's got to get carried to the tissues, and then it's got to get into the tissues, and then the tissues themselves make a decision. Do I want to convert this to active hormone, or do I deactivate it to a less functional form? And tissues get to control what happens. And the allopathic community kind of doesn't really pay too much attention to that. But when you think about it, for the person who is struggling with hypothyroid symptoms but has a normal TSH, their gland still seems to be producing enough T4, they're in that kind of early phase, that cell phase, that tissue phase of hypothyroidism. They've got cells or tissues that are perceiving danger and are trying to actively slow down metabolism as a protective mechanism. And they could be in that mode for days, weeks, months, years before there's enough damage that occurs to the thyroid gland where it becomes dysfunctional. And so we got this early phase, this tissue phase of hypothyroidism, and that's that's where people, I think, get really frustrated because they may be starting to have signs and symptoms. They might really feel like they've got hypothyroidism, and they actually have it at the tissue level, but it's not showing up on just the TSH and T4 because the gland is still producing enough. It's just not converting. I guess a good analogy would be, they still have a full tank of gas, but the gas isn't getting to the engine, right? So the car's not running. It doesn't matter how much is in there. It's not being run. It's not going to be able to run the system. So I think that's like the first phase, excessive cell stress that triggers that cellular hypothyroidism. And then the longer we're in this kind of danger physiology, the more these cells in stress, in danger, release signaling particles to activate the immune system. And so they throw out these things called DAMPs and PAMPs that activate the immune cells to come help, right? I've got a bacteria, I've got a virus, I'm being damaged, something's threatening me, and the immune system, your white blood cells, come out there to try and help. That's part of what their job is. And they also can release these things called PAMPs, which are pieces of the organism that go out into the bloodstream to tell the immune system, like, hey, here's the bacteria, here's the virus you're looking for, now go find this thing and get rid of it. But those DAMPs and PAMPs are circulated in the bloodstream, and the thyroid gland has receptors for these DAMPs and PAMPs, and when they bind to the thyroid cells, it initiates self-destruction of the thyroid cells. The thyroid cells actually become immune-like cells and start to create inflammatory damage and release signaling molecules to invite the immune system in, and that triggers what we call like kind of that next phase 2, which is like the thyroiditis, the damage at the thyroid gland. And
which is where the allopathic model would say that starts.
That's
when people would say, yeah, I've now got a thyroid problem, is at that stage.
If their TSH is high and their free T4 is low, right?
Mm-hmm. Yeah.
If they ran thyroid antibodies, but very few people get thyroid antibodies done, right? So we can't see it. What Datis Karazian kind of talked about before, and Dr. Vujadani has talked about, is that the antibodies, they call them predictive antibodies. It doesn't mean necessarily that we have damage or destruction to the gland, but they indicate that there's damage to the gland when we start to see the antibodies rise. And so it doesn't necessarily mean it's like these little antibodies are like little pac-man eating it up. I think that's what we used to think, and people still kind of talk about TPO antibodies creating all the damage to the gland, but it really isn't the antibodies that cause the damage. It's more the infiltrating white blood cells. When the allopathic community is going to come in and say, oh, now you have a problem, is when the TSH actually rises above lab range. Until that point, they're not going to say, they don't really care about your antibodies because they're not treating antibodies. They're not going to treat your immune system. So they're only worried about it. But that's really the last phase of the thyroid condition, is when you actually have enough glandular destruction that you get diagnosed with primary hypothyroidism. So you go cellular hypothyroidism, thyroiditis, subclinical hypothyroidism to clinical all-out glandular hypothyroidism. And that's the spectrum. And unfortunately, most people don't realize or get diagnosed appropriately until they're into that last stage, right? Mm-hmm. And so at that point, you've lost a lot of function of your thyroid gland. And depending on how long that's been going on, it may be really hard for that thyroid gland to really recover.
Yeah. And so is the autoimmune, when you're talking about Hashimoto's and the autoimmune component, does that sit sort of beneath all of that, or is that a final stage to the spectrum? Like, where does that sit in the spectrum, or is it
that is the thyroiditis? Yeah, so that is the thyroiditis. So when people think about autoimmunity, I think this is where there's a lot of confusion, right? Do I just have thyroiditis, or do I have an autoimmune thyroiditis? Because they make the differentiation, well, if I have antibodies, I have autoimmune thyroiditis. If I don't have antibodies, I have just thyroiditis. Thyroiditis is driven by the immune cells coming into the thyroid gland and creating damage. That's your thyroiditis. And so whether you have antibodies or not really doesn't matter, whether it's still immune driven, right? I think the thing we get hung up on is we've been told for years that the antibodies are like little pac-man eating away the thyroid gland. And so it's just thyroiditis, but if you see the antibodies, that means they're going to gobble up your thyroid gland, and it's autoimmune. Your immune system is attacking and destroying your thyroid gland. Well, your immune cells are damaging your thyroid gland to begin with. The antibodies are just an after effect. And when we look at thyroiditis to begin with and Hashimoto's, it often starts off as a Th1 dominant disorder where no antibodies are initially there. And then you can have a shift to a Th2 dominant thyroiditis, which is where you'll see lots of antibodies. So it really depends if the person is Th1 or Th2 dependent, what phase of that immune balance they're in, because there's a lot of people that have thyroiditis, they're struggling, and as they get healthier, they go from no antibodies to now all of a sudden seeing antibodies, and but they're better. Their thyroid gland's regulating better, their numbers are better, and they're thinking, oh, am I getting sick now? No, your immune system's finally balanced. When you run lymphocyte panels on people and look at their actual white blood cells and their CD cells, you can see that some of these people, they're like, I don't have Hashimoto's because I don't have positive antibodies. Well, right, because you're Th1 dominant. You're probably not going to produce those. So as you get healthier and you get this imbalance, the balance of the immune system starts to level out, it's not unusual that they start to see some antibodies. But people get really hung up on the antibody thing, and I did too early on, because it was like, how do I lower antibodies? How do I lower antibodies? What can I give somebody to lower antibodies? I don't know that makes it's as important as we think it is. The issue is, how do I calm down this immune damage to the thyroid gland, not so much the antibodies. Because if you read the papers in the last 2 to 3 years, there's a number of papers that say that thyroglobulin antibodies cause no damage, none, to the thyroid gland, and TPO antibodies cause very little damage. And one paper said less than 5% of the damage is actually done by the TPO antibodies. Right, wow. Yeah. So we make a big deal about antibodies, right? Like, oh my gosh, the TPO, you need to do this, you need to do that. And the reality is, they probably don't cause that much damage at all.
Wow. Yeah,
so that changes.
Yeah, it does, doesn't it? Yeah. Although, does it change the treatment in the sense that if it's all about reducing inflammation and that the need for the cells to be in that cell danger mode and self-protection? Do you know what I'm asking?
Yeah,
the outcome doesn't, maybe the antibodies don't matter so much, but because the outcome is, the process to maybe reduce the antibodies is the same as it would be to dampen that inflammatory response.
Well, yes and no, right? Okay. So if your goal is, I want to do something to lower the antibodies, let's say, and this is controversial, but I'll talk about it because everybody talks about pounding everybody with vitamin D. So, hey, if somebody's got high TPO antibodies, give them lots of vitamin D. That will lower their TPO antibodies. Yeah, but it may not change their thyroiditis at all, because that may push the other side of the immune system. And is that what we want? Not necessarily, right? So I might be able to do things to hide the antibodies, so I don't see them, shift the immune response. But if I still have immune activation that's being driven by DAMPs and PAMPs and danger particles, I'm probably going to still have the same thing. But I learned early in my training, hey, the antibodies are the thing that are eating it away. But in trying just to suppress antibodies, I was struggling with having those patients see success. It wasn't until I started reading more of that literature that it was coming out and going, you know what? We're putting a lot of effort on how to lower antibodies. How about we just reduce the things that are creating the excessive cell stress, that are creating the immune activation? And if we do that, guess what?
Then
they go down anyway.
Yeah.
Okay. So
that's what I was wondering. Yep.
I just went through blood panels with somebody today, and their antibodies have come down every blood work. What have we done to directly try and suppress antibodies? Not one thing. What have we done? We've reduced we've cleaned up their diet. We've worked on breathing exercises. We've worked on sleep habits and behaviors. We've addressed some of the bacterial infections. We've removed foods that are reactive. And guess what? Antibodies are getting better, right? So they've gone
so
from
it's more the outcome, not the goal. Is that what you're saying?
Yeah, I think
it could be the outcome, but it shouldn't be the goal.
Well, yeah, I'll watch antibodies, right? And if they're coming down with what we're doing, that's great. But I'm not trying to manipulate. I'm not trying to whack-a-mole the number down, okay?
Okay.
Just trying to say, hey, if I'm going to try and get the antibodies down, people think if they get the antibodies down, they've fixed the problem. And what I'm trying to say is not really, because it might be still immune system still damaging the thyroid gland, but just not producing antibodies. Okay? Because you could have thyroiditis, no antibodies. I see that all the time with people. No, they have no antibodies, and then 6 months later, now I've got some antibodies. Yeah. You were Th1 dominant. Now your immune system is more balanced. You're starting to see some antibodies. Don't worry about it. There's damage there. I like to tell people to think of the antibodies as the cleanup crew. they're not doing the damage. They're doing more of the cleanup. They're cleaning up the debris. So if you think about it that way, if I see high antibodies, I know there's a lot of destruction. I need a lot of cleanup crew to go out and do it. As I see lower antibodies, by doing all the things to reduce the cell stress, then I know there's less thyroiditis, there's less damage to the gland. I don't need as many people to clean the place up. So antibodies go down. But you could have the thyroiditis going on. There could be a lot of people damaging the thyroid gland and no cleanup crew shows up for a while, right? And that's where we see people have bad thyroiditis. My thyroid gland's popping out of my neck. I feel like I'm getting choked. I've got this thing going on, but their antibodies are negative. No, you don't have the Hashimoto's. You don't have thyroid. You have thyroiditis. It's not Hashimoto's. No, you have thyroiditis, and it's probably Hashimoto's. It's just a matter of time till the antibodies show up.
Yeah. Okay. That's helpful. Yeah. And so just want to ask a question about the diagnosing, because if there's destruction or cell damage going on, or this tissue hypothyroidism. That probably didn't word that right, but when we're talking about that cellular tissue hypothyroidism, and it takes a while for that to develop into the glandular hypothyroidism, and then for it to show up in the blood, is there a way of testing, or how do you know whether you've got cellular hypothyroidism in that early stages? Is it just that you've got symptoms? Is there a way of testing for it? How would you know?
Yeah, so we don't have a direct test of what's going on inside the cell. So we have to look at proxies of what's going on at the cell. So when I'm looking at a blood panel for somebody who thinks they have a thyroid condition or struggling with weight issues, and they're like, I think, I've been diagnosed with hypothyroidism, but I still don't feel well. First thing I want to do is I want to look at their thyroid panel, right? I'm going to look at their thyroid panel and say, what's going on? So TSH, T4, they're important, but the first things I'll take a look at is what's their T3, what's their free T3, what's their reverse T3. I'm going to look at those three values. If their T4 is normal, their T3 or free T3 is low, I'm probably not getting very good conversion in the peripheral tissues of T4 to T3. Most of the T4 in the body or T3 in the body is made by the peripheral cells converting. We learned in school that most of the T3 is made in the liver. That's no longer true.
Yeah, I did pick that up. I thought, that's what I've said. I've always thought that the liver and the gut, but it's not.
That was it.
It's really,
that's what I learned.
Yeah. Okay. So that's wrong.
Every cell.
Stop saying that. Yeah. Every
cell that has the ability to convert T4 to T3, it brings T4 in, converts it to T3. The T3 binds to a receptor, hangs out there for a while. Then it comes back out of the cell, becomes part of that circulating pool. Okay, so it's thought that the liver makes maybe 5 to 10 micrograms. The GI tract maybe make another 5 or so. And then all the rest of the tissues make up the other 20 micrograms that are made through the day. So thyroid 5, liver 5, gut 5, and the other 15 to 20 is made by what all the rest of the peripheral cells are doing. So that changes the game versus, it's just the liver makes it. All the tissues contribute to that circulating pool. So if the T4 is normal, T3 is low, I know that, and the patient's got hypothyroid symptoms, this is probably a person who's got tissue hypothyroidism going on. Now I got to figure out why and what tissues are being impacted by it. I'll look at the reverse T3. If reverse T3 is high, why would reverse T3 be high? If they're not on medication, it's because the cells are deactivating the thyroid hormone. So what's the enzyme that actually does that deactivation? It's called deiodinase 3. What triggers it? Hypoxia and inflammation are two big things that drive it. Okay, well, now let me look at my metabolic panel and find out, do I have markers of inflammation? What's my uric acid? What's my ferritin? What's my CRP? What's my homocysteine? What's my fibrinogen? If I've got multiple markers that indicate inflammation or oxidative stress, guess what I probably have? I probably have downregulation of the cell metabolism, tissue hypothyroidism. Now I want to see what tissues and what systems are impacted by it. So I'll go look at the lipids. Why? Because for T3 supports every enzyme that regulates lipid physiology. So if I've got high cholesterol, and I've got high LDL, I know I've got low T3 state in the liver because I can't get cholesterol out of the bloodstream. LDL needs to dock to the receptor, dump off the cholesterol. So if I don't have enough T3, the LDL receptor doesn't work, cholesterol is high, right? So that may be an indication. I can look at triglycerides and VLDL. If triglycerides are high, I'm not able to burn fat. What do I need to burn fat? I need T3 inside the cells because T3 drives mitochondrial function, which is what you need mitochondria and oxygen to burn fat. So if I've got elevated triglycerides, elevated VLDL, I know I've got problems. So I'll look at those values. The other thing I'll do is I'll look at insulin signaling. I'll go and say, is this a person who's struggling with glucose regulation? What's their fasting glucose? What's their fasting insulin? What's their hemoglobin A1C? If those are elevated, hey, I probably got tissue hypothyroidism that's affecting the liver and muscle tissue. Why? To get glucose into a cell, guess what you need? You need glucose transporters,
Energy.
and all the glucose transporters need T3 is what helps get those glucose transporters there to bring it in. You can look at the gallbladder, and there's markers of poor bile flow and poor bile function. Guess what you need to make bile flow and bile function? So I'll just start going through systems and start saying, how's my liver functioning? That indicates we've got slowed metabolism at the liver. How's my blood sugar regulation? Shows like I got resistance. I'm having a hard time getting glucose in. Cholesterol is high. You can look at your adrenal gland. Everybody talks about adrenal fatigue. Got to fix the adrenal gland. You got low cortisol. Well, guess what you need to make cortisol? You have to bring cholesterol out of the bloodstream into the mitochondria and convert it into cortisol. Well, guess what you need to do all that? You need sufficient levels of T3 inside the cell to do it. Yeah. So when you look at a comprehensive blood panel and you understand what systems need T3, you can look at that and say, listen, you've got a pancreatic problem, that you have low T3 affecting your pancreas, you got low T3 affecting your blood sugar regulation, you got low T3 that's affecting muscle, liver, gallbladder. I mean, you can start to see where you start develop what I call a multi-system adaptive disorder, meaning every system starts to become compromised. Why? Because T3 plays such a vital role in the manufacturing of so much stuff that goes on in the cell. And anytime there's cell stress, the body says, hey, we're going to shift from manufacturing to cell defense. And the way that it pretty much does that is reduce the amount of T3 inside the cell. So there is no direct measurement, right? Like, oh, that's what's going on inside the cell. But if we look at T3, free T3, reverse T3, we could look at the ratios of T3 to reverse T3, free T3 to reverse T3, free T3 to free T4, which is missing from the book, by the way. I forgot that one in the book. Then we can really look at the thyroid panel and see it. Do we have inflammation? Look at the rest of the stuff. And I did a Thyroid Thursday on this where I kind of laid out all the hypothyroid patterns at different tissues so somebody could be able to say, hey, my TSH is normal or low, but I got tissue hypothyroidism going on. So that's... I explain a bunch of that in the book as well. Yeah. There
is a lot of detail about all of that, and can you just explain a little side thing, and we'll come back to the multi-system adaptive disorder because I think that's really helpful. What's the difference between the T3 and free T3? And the tests, like, should we be getting all the tests, like all of like the free and the non-free?
Well, I know that we used to do TSH and total T4. And total T4 means the thyroid T4 that's free, available to get into the tissue, and T4 that's bound to the protein. So for the listener, your body has two primary thyroid hormones, T4 and T3. They need to be shuttled around the body. So once they're produced, the body puts them in like little binds them to proteins, like little taxi cabs that drive them around the bloodstream, right? And as long as they're on this protein, we call that bound hormone. That bound hormone can't work. It has to come off the protein, out of the taxi cab, so it becomes free, and that's what then enters into the cell. We don't want to be flooded with free hormone because if we're flooded with excess free hormone, that can react. And remember, thyroid hormone can bind to receptors inside the cells, but thyroid hormone can bind to receptors on the outside of the cells and create issues. Okay, one of the things
because it's not getting in. that
Yeah,
right?
well, there's different types of receptors. They're called integrin receptors on the outside of the cells, and thyroid hormone, especially T4, can bind to those receptors. And so thyroid hormone has both genomic, activates the genes inside at the nucleus. It has receptors at the mitochondria, but there's receptors on the outside of the cell that still drive a lot of processes without touching the genetics. So that's a whole complicated discussion, but a very simple thing and a really important study that I thought would never get done came out. And if one of the things that T4 can do when it binds to the receptors on the outsides of the cells is it can trigger cell replication. Okay, so now think about that. If I have some sick cells that are trying to downregulate,
that's an unhealthy cell. That's not so good, is it?
No, it's not. So when you think about that, what could happen if I flood my body with thyroid hormone and it can't get in? It's not getting into the cell, and it's binding to these receptors excessively on the outside of the cell. When you have multiplication of a lot of sick cells, what do we call that?
Yeah, that's the cancer connection, isn't it?
Yes, it is. And I cite the paper in the book because
I highlighted it. Yeah.
I said to Kelly a couple years ago, I said, Kelly, listen, here's my concern. People get put on medication. It's not getting into the cell. It's binding to the outside of the cell. And they're going to be developing cancers down the line that nobody even ties to their thyroid hormone. And she's like, somebody needs to do a paper on that. I'm like, nobody in their right mind is going to do a paper on that. Who's paying for it, right? And in 2019, the paper came out, and they started showing the statistics of what the percentages were. There's an increased rate of cancer, almost every type of cancer in people on thyroid medication. I
actually remember when that study came out, because it went around all of the thyroid groups, and I think as someone who's been on thyroid medication for 25 years, I was just like, la 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 la, don't want to know. Yeah.
Let's put our hand in the sand and pretend it's not happening. But the reality is, that's a reason why we really got to change what we're doing. We just can't flood people with like in the American mentality, if some is good, more is better. So let's just give it. And we have to think about the body really tightly regulates this stuff. So it is important that we don't give too much just to try and force physiology, because we may be forcing the wrong physiology. Yeah. So to get back to your question, same thing with T4 like as I was talking about T4 and free T4, same thing with T3. Total T3 is what's bound and free, and then there's free T3. Allopathic medicine and even in functional medicine, they've moved to the free, just measuring the free fraction, because that's the only part that counts, because that's what's going to get into the cell. And that's not true, because we need to know how much total we have to begin with. Because if we don't have much total to begin with, we don't have much reserve. You can see the
proportion of how much is bound and how much is free.
Right. So, hey, I don't care what if I said to you, listen, I'm going to give you $5, right? 5 ones. That's great. But I'm also going to have this, I'm also putting $1,000 in your pocket that you don't see, right? Isn't that part, $1,000 that's in your pocket, isn't that part important too?
Yeah.
So we need to know what we're starting with to be able to be free. So I think you got to know the total so that you can understand what the free value actually means. Because if we look at the total, if we have a TS8 or a free T4 or a free T3 that's relatively low, is it because I don't have enough T4, or is it because it's all bound and stuck on the protein? Right? Because if I have high estrogen is going to increase my sex hormone binding globulin. It's going to increase my thyroid binding globulin, which means I'm going to have more thyroid hormone that's stuck on the binding protein and can't get out. So does giving more thyroid hormone fix that? Probably not, right? Yeah. So giving more in that situation isn't the solution. The solution is, how do I reduce my estrogen? How do I reduce the excessive binding globulins? So for the listener, like, the difference between bound and free, if you wanted to go to the mall and you asked me to take you to the mall, I'll drive you to the mall. I'm the binding globulin. You're the sexy thyroid hormone, right? We get to the mall and you go, all right, I'm getting out. Nope. You asked me to bring you to the mall. You didn't say you were going to go into the mall. We're going home, right? And you could say, well, I didn't get to go shopping. Well, you wanted to go to the mall. I took you to the mall. Just like the binding globulins, they'll take you all over the body. You look at the total. If you just look at the total hormone production, you might say, hey, there's plenty. But I need to know what's free, but I also need to know what's available so I can determine what's the right strategy to help somebody. Does that make sense?
Yeah. Yeah. Oh, it does. But it just leads right into, I think, still this multi-system adaptive disorder, and just how I always thought thyroid was complex. I feel like I've lived some complexity and I've done enough reading and research to know that it's complex. But I think reading your book and just made me really, I think it just solidified. It really is complex and it really does impact everything. And so tell us, what is multi-system adaptive disorder in this context? Like what does that mean, and what do we do with that in our understanding of thyroid health?
Well, I think everybody wants to kind of just hang a hat on what their disorder or condition is, right? So I would have people come in and say, well, I think I have fibromyalgia and I have adrenal fatigue syndrome and I have Hashimoto's and I've got, I'm like, or they're saying, like, what is it? What can I tell everybody that I have?
Uh-huh.
Okay. You need a name, right? Yeah. Because everybody thinks I'm just faking it
Crazy.
or whatever. Okay.
Yeah.
Here's what you got.
Yeah.
You have a multi-system adaptive disorder, right?
Okay.
That's what you have.
Yeah.
So what does that mean? That means you have excessive cell stress that's causing your physiology to go from manufacturing mode to cell defense. And because of that, I have less energy. And because I have less energy, I'm turning down the amount of energy I'm using on my GI tract. So my stomach acid production is going down, my bile acid production is going down, my pancreas is going down. So now I have constipation and my bowels don't work good. So I got a GI problem. And that's not necessarily broken physiology, it's adapting, right? So I've got an adrenal problem. Well, of course you do. You have excessive cell stress. Your adrenal gland is now acting like in danger mode. And so you might have either an increase in cortisol or a decrease in cortisol based on what phase you are in that. I've got sex hormone issues. Absolutely you do. It's not broken physiology. You got excessive stress going on. You should totally expect your sex hormones to get screwed up, right? And the analogy I use to people is, if you were being chased by the tiger, would you stop and have a meal?
Yeah.
No. Right?
No.
Would you stop
you
and take a nap?
You're about to be the
right?
meal.
Right?
Yeah.
Would you stop and have sex? Would you do anything? No. Why wouldn't you do it? Because those things aren't important. I'm trying to save my life. Right. So are your cells and tissues. They're trying to save your life. And they're saying, what is the least important processes going on right now? Making sex hormones is really not that important when I'm in danger mode. Right? I'm not procreating in that moment. So when you have this excessive cell stress that's pushing you into danger, you should expect, not be surprised, that you're going to have multiple systems start to become compromised. So instead of thinking I've got a GI issue that's not associated with my thyroid issue, I've got an adrenal issue that's not associated with my thyroid condition, I've got a sex hormone or a menstrual cycle issue that's not associated with, all these systems are all tied together. When you have excessive cell stress and you have downregulation of your metabolism, should be expected that every system in your physiology is going to start to struggle. So that's your multi-system adaptive disorder. And we call it an adaptive disorder because we don't think that this is a body that's just, my adrenal gland just gave up one day. It just decided it wasn't going to work, right? No, your adrenal gland had to change how it worked because of what the physiology was telling us. Whoa, we don't need more cortisol production. We can't make more. We have to put the time and attention into something else.
Yeah. So I just often say it all. I don't know. Thyroid sits behind everything. So really, it's sort of cell response, cell danger sits behind everything. Really, might be the better way of putting it. Yeah.
And that's why we say that, this book, even though it's written through the eyes of thyroid physiology, is a book for everybody. Who doesn't matter what your condition is, because we're talking about why cell physiology changes through this window of thyroid physiology. But if you have gut issues, the same principles apply. If you've got adrenal issues, the same principles apply. Your physiology changes because of the excessive cell stress. And the solution to almost every chronic health condition we have is try and identify what those stressors are and remove them or reduce them to a point that the danger physiology goes away and the body can start to shift back into repair and regeneration mode. I think sometimes I was on a conference call last night. I had to do a presentation last night, and somebody said, well, I think my patient has mitochondria. They don't have a thyroid problem. They have a mitochondrial problem. Like, no, your patient has a cell danger problem. And so the cells perceiving danger automatically down-regulate the mitochondria. And they were like, well, why would it do that? I'm like, because when you make a lot of energy through your mitochondria, you make a lot of exhaust, free radicals, right? And so when we try to fight an infection or an organism, guess what we do? We make excessive free radicals. Why? Because those free radicals are used to kill the organism. But if I'm making a lot of free radicals to fight this threat, and I'm generating a lot of free radicals through the mitochondria, guess what I get? I get excessive free radicals that my antioxidant system inside the cell can't match. And guess what happens? Now I destroy the cell. The body's pretty smart. It down-regulates the mitochondria, so it says, hey, little bit of exhaust, just enough energy to run this stuff, just like a generator running your house after a power outage. And we're going to control how much free radical formation that we have, so it kills the threat, but it doesn't kill the cell. Does that make sense?
Yeah, it does. Yeah, it does. So there's probably all these different conditions that are being really, in a sense, misdiagnosed or misunderstood, because they're not looking at it from that cell danger response perspective. And the way our medical model is like, oh, you've got, this problem, go see that specialist, this one, that one, this one, that one. And so that's how you end up with this, well, your whole body, you're not just a heart or a lung or a head or a, yeah.
And when people say to me, well, I'm coming to you because you're a thyroid specialist, I usually tell people, listen, I'm not a thyroid specialist. I think I'm a pretty good generalist. And I think that's what a good functional medicine practitioner has to be. I had a new consult today, and the person said, hey, I'm coming to you because I know you wrote a book and you're a thyroid specialist. I'm like, listen, be honest with you. I'm a really good generalist. I don't do anything to directly try and manipulate your T4 or T3 directly. I'm trying to do it all indirectly by trying to look at all the other systems in the body and try and help them recover. And they're like, but what are you going to give? What are you going to give me to help my T3? I'm going to look at your system, find out what's causing excessive cell stress, reduce that cell stress, find out what systems are struggling, and support the recovery of the tissues. Your body won't heal and when it's in danger mode. That's the thing when you see people that I got a gut issue. I did a SIBO treatment and it came back. I did this treatment for my gut and it came back. I got this and it helped for a while and it came back. Why did it come back? Because they weren't in repair mode. You're loading them with supplements that are going to change that environment temporarily, but ultimately the cell physiology isn't in regeneration mode. It's in cell defense mode. So you're not going to have long-time healing and repair in that mode. Your body's not putting attention to cell-to-cell communication and optimal function. One of the things in some of the papers you'll read that when cells are perceived danger, they stop their cell-to-cell communication or reduce that cell-to-cell communication. That cell-to-cell communication is critical to the environment of the tissue to be healthy and to be well. Just like us, we need to have person-to-person communication or we start to have problems. Our cells have the same thing. So the last phase of kind of rebuild or regeneration is the full restoration of that cell-to-cell communication. But sometimes just doing a short-term supplemental strategy without identifying what the real stressors are gives a short-term benefit, but then it goes right back. And I think when I try to explain to people the idea of what somebody was trying to do for you was good, but you still had the excessive emotional stress. You still had disrupted sleep. You still had poor breathing patterns. So the environment was the same. right? So
yeah, which leads us right into the third part of your book, which is all of the strategies that you can do to help, deal with this, on a really practical level. And you talk about the wheel of wellness and 10 different aspects of your life that you can address in that really practical way. This is how you can actually, reduce that, stress response. Is that right?
Yeah.
Is that the way you see it?
The things that create illness are a lack of, we call them fitness factors, right? We talk about physical fitness, dietary fitness, respiratory fitness, sleep fitness, emotional fitness, environmental fitness, habitual fitness, your microbial fitness, your metabolic fitness, and your genetic fitness. And fitness, how fit, how healthy you are in each one of those categories determines your overall health and well-being, right? And so if you don't have good dietary fitness, your overall health is going to decline, right? So as these things decline, as you get worse fitness in each of these categories, and you start to decline in each of these categories, that's what causes chronic illness and disease. So if those are the things that are creating chronic illness and disease, the solution isn't in a bunch of bottles. The solution is, how do I improve my respiratory fitness, right? And people
that was a good one, because I thought, that's something I hadn't really thought a lot about. And that was my question was, of those 10, I mean, obviously we're not going to have time to go into all of those, but I mean, are there some that people sort of overlook more than others? And I would think respiratory fitness would fit into that category.
Top of the list, and nobody wants to talk about it. Nobody wants to work on it. Nobody wants to address it. Everybody says, I breathe fine.
Yeah, because I read it and I was like, breathing exercises.
See, nobody likes to do them, right? It's not sexy, right? But let me give you, I have my patients.
Do you want to talk about it for a minute? The respiratory,
yeah.
That's something that we overlook. I'm happy to go there.
Here's the thing, right? So there's 3 simple tests I talk about. A simple breath test with my clients. I talk about how many respirations per minute, and then a controlled hold breath time test. 3 simple tests everybody can do at home to get an idea of, do they have optimal breathing? And I think people are surprised, because how many respirations per minute is considered normal or average, and how many respirations per minute is considered optimal. So the average is thought to be somewhere around 16 to 18 breaths per minute. Okay.
Oh, okay. I did the test, by the way, when we were doing that.
Did you?
Yeah.
So the optimal respirations per minute is 6. So 6 breaths in and 6 breaths out is optimal breaths per minute. Optimal. Okay.
Yeah. Wow.
I tell my clients, listen, if you're under 12, you're doing better than the average, but you should be shooting to under 12. We talk about another test, a controlled hold breath time test. That should be closer to 40 seconds for optimal, right? That's a test where you blow all the air out and you try and just sit without air. And how long till I get uncomfortable? And most of my patients are somewhere around 15, 20 seconds, and then they're starting to have anxiousness. But a couple little things to consider. One of the big issues we have in this country, probably yours too, is people are struggling with sleep apnea, right? And the other thing that people struggle with is they wake up at night a lot to pee, right?
Okay. Yep.
What's going on there? Well, when you don't breathe appropriately, you have disordered breathing. At night, when you lay down, you already got inflammatory issues, right? Now fluid accumulates, soft tissues swell, the soft tissues kind of collapse in, nasal passages get congested, and now you can't breathe through your nose. You open your mouth to breathe. You don't even know you're doing it. Everybody says, I don't do it, but most people do. And now you're breathing through your mouth all night. That causes you to lose too much carbon dioxide. It means you're not getting, and without carbon dioxide, you can't exchange oxygen to the tissues. That causes tissue hypoxia. That upregulates your sympathetic nervous system, and now you're going to be more alert. It is going to create hypoxia that's now going to downregulate your cell metabolism, which is going to lead to slower metabolism and weight gain. 3, it leads to reduction in something called vasopressin. And when you have a reduction in vasopressin, now you don't resorb as much fluid from your kidneys through the night, and you make more urine. So now you're breathing poorly through the night. You're not getting restful sleep because your sympathetic nervous system is constantly kicking into gear because you're essentially choking to death as you're sleeping. So you never get into deep restorative sleep. Your sympathetic nervous system, your inflammatory system's kicked up, so you feel you have more inflammation, so you're going to feel more discomfort, more pain. And because you're stirring and you're not getting in deep sleep, you're feeling more pressure from this urine that's accumulating excessively in your bladder, and you're getting up to pee multiple times through night. And then when maybe you get back to sleep, and the next day you get up, and I'm exhausted, right? And then you wonder why. And I'm gaining weight, and what's going on? Just the poor breathing, this disordered breathing, could be a major factor that's triggering tissue hypothyroidism, high blood pressure, terrible sleep, and sleep apnea, and a bunch of these other things. And it's free to work on. Tape your mouth shut, do breathing exercises. Nobody wants to do them, but it's so important. And it's simple things like that, but it's
often the simple things, isn't it? That they're simple, but they're hard. They're simple, but you've got to do them on a regular basis. You can't just do it once. Yeah.
It would be great if there was
lifestyle stuff. It's all the diet and lifestyle stuff. Yeah. It'd
be great if there was a pill, right? But it doesn't work.
Yeah.
That's not really the best strategy. You can take melatonin, you can take GABA, you can try and drug yourself to sleep, and that may work short term. But if you don't change the respiration, you create a cascade. Poor breathing has been associated with almost every chronic illness we have. Why? Because it creates excessive cell stress, changes and shifts you into allostatic regulation. There's a reason there's no supplement recommendations in part 3. Because the last thing I wanted to do is what everybody does is they say, I'm going to go buy selenium, and I'm going to go buy some tyrosine, and I'm going to go buy, and then they go buy a bunch of stuff, and they ignore the most important things, which are those building up their fitness factors.
Yeah. And and really that my book is much simpler it's simpler. Well, it probably is a little bit. It is simpler, but that was the point of my book. Was like, you have to do these lifestyle things. I'm not coming at it from the same perspective. I'm coming at it from a patient perspective. But you can't just take medication and or supplements and think everything else will be fine. You have to do the other things.
Yeah.
And I think what you've done is really a much more comprehensive look at the other things, so some of the things overlap, but it's much more comprehensive. And so I think what I liked about that as the way of ending the book was that after a lot of heavy science and a lot of mental, it wasn't easy, but living with a thyroid condition isn't easy. So if you live with a thyroid condition, understand your life's not easy. It's not easy to understand, but we've got to put in the effort. So it's worth the effort. But what I liked was that it ended with these 10 areas that really we can spend the rest of our lives working through these things. You don't have to do it all at once, but if you ignore them all, then, you're probably going to feel like crap. That's the bottom line, isn't it?
If you do those things, because I see this in my practice, right? You got a husband and wife, I'll be taking care of one of them, and they're working on these lifestyle factors. They're working on the diet together. They're working on the lifestyle factors together. And I just had one of my clients in today, as we were working through her process over the last 6 months, her husband lost, I think, 65 pounds. And he's like,
wow,
I've lost 65 pounds just doing the lifestyle stuff that you've told her to do. So he was, he was overweight, obese. And guess what? He had, guess what he had? He probably had cellular tissue hypothyroidism. Yeah. We didn't use one supplement. We weren't even addressing him. He was just going, okay, I'm going to eat a whole food, real food diet. Okay, I got to do the breathing exercises. All right, I got to work on these sleep things. I got to work on this emotional stuff. All he did was just work on those things. And he's like, I lost 65 pounds. Right.
Yeah.
He's like, now I'm all in. If I can do that with
Yeah.
just a few things, imagine if you help me with it, just really identify the other things that are, the things that I couldn't do. I don't know what microbial fitness looks like. Can we take a look at that and see what's going on there? Right. So that's the exciting thing, that if you do the things that you talk about in your book and I talk about in my book, the stuff that's not sexy, the stuff that's not in a bottle, you can get healthy and you can get well. And these are the lack of health in each of these categories is the reason you're sick to begin with. I just had a client I talked today, and he just was in Nicaragua for a mission trip, and he said, like, hey, these kids, we feed them and they only get one meal a day. And I said to him, hey, how many of them are obese? He's like, none. I said, okay, did you notice their teeth and their smiles? He said, you know what? I did notice it. Those kids have perfect teeth. I said, so think about this. Those kids, they don't get more than a meal a day. It's probably not great food, right? On their own. They got tons of stress. They may not realize they got stress, but they have stress or some of the stuff that goes on. And I was like, and they have perfectly formed mouths and teeth. Nobody's pulling out extra teeth. They're nice and straight. They look, he's like, they are. And I'm like, yeah, why do you think that is? He's like, because they're not eating crappy food. I'm like, right, because they're not eating crappy food that's creating chronic inflammation, that's narrowing their nasal passages and making them inflamed, and they can breathe through their nose. And so if they can breathe through their nose, they're not having the same inflammatory effect from poor breathing and poor diet. I mean, their diet's not great if we're honest about it, but the fact is they're not eating a ton of inflammatory food, and they're able to breathe better, and so their oral cavity is in better shape. It's amazing, and so it's just an odd thing when you look at that and go, wait a second. What is happening? Every kid here in the States, what do? They, when they hit 13, they got to get braces for their teeth to get them straightened out. No, your jaw's too small. We got to pull teeth out. What? Why didn't that jaw develop appropriately? Probably because of poor breathing early on in life.
Yeah. Oh, look, that's another whole fascinating conversation. We could keep talking all day, but you've got to go have dinner, get on with your night. And, I could talk about this with you. I find it all fascinating. I said to my husband, I think what Eric needs to do is, needs to turn this into a 3 or 4 day course, because that would be really great. I would come to that.
It's in the works. We are going to put a course together. Yeah. And, I think. Well, I'll leave that. We're going to definitely have an online
It's okay. Yeah, I put you on the spot. It was more like, I would love because I think it is that sort of thing that in that course delivery, you could unpack it more. It's just another way of presenting that information. And I think because it is meaty and but it's so important to get it, and I think it is the sort of information that we need to get in a few different ways. So listen to the podcast, follow you, listen to your Thyroid Thursday, talks on Instagram, and
And I think keep listening to what you're doing, right? Because we need different perspectives on what's going on, right? And different levels of communication. I think what you've done with your book and your podcast has been really beneficial to the community of people who are like, hey, I'm just trying to dip my toes into the water here. Where can I start? And I think your book is a great opportunity for people who are especially new to what's going on with their health when they get diagnosed with a thyroid condition, or I think I have a thyroid condition, where they can kind of dip their toes in before they get maybe a book where it's a little heavier. They can say, okay, give me the starting point, right? So I think you did a really good job of making it a fun read. The book's fun to look at. It's fun to read. You did a really good job with it. So I think that's good. So we need more people having these discussions about how health and physiology works, and the importance of doing these fitness factors and working on those. Instead of focusing on why am I sick, just focus on raising your level of fitness in each one of those categories we talk about in the book, and you'll probably get healthy by accident.
Yeah. Well, or not by accident, but through deliberate strategy. Well, Eric, how can people get a copy of the Thyroid Debacle? Where do you want people to connect with you and get that from?
So you could go to Amazon.com. I know it's available. I think Amazon wherever you are in the world. Amazon, I think, is around. So you can get it in soft cover. Some areas I heard there is hardcover, some areas not yet. And then there's, I think there's a Kindle version out.
Yeah, there is, because that's what I got. I needed to get it faster than the paperback. So,
but
yeah,
it is a. But I think you can get it. Amazon, Barnes and Nobles is what we have here.
Yeah. Okay.
There's, I think those are the big places to get it. If you can't find it, message me. We'll figure out.
And I'll put links because I found it. It's not hard to find. And I'll make sure I link to that too. Mm-hmm. So, but thank you very much. And, maybe we'll have another conversation at another point down the track, and let me know.
I'd love to come back, have another conversation. I plan on having you come back on my podcast. I love nerding out on this stuff. I think it's fun. It's interesting. And I think it's helpful for the people to hear this message over and over again. So they can finally start to get it and understand it.
Oh, totally. I mean, I've had to listen to things over and over and over again. So we all have to listen to things, and as you say, different perspectives. And I've got to say, that's what I love about the podcast platform is, get to talk to lots of different people, different perspectives. I've got a lady coming on I'm talking to her next week, and she's a person that's connected with me through just through the Facebook group and then the podcast. And she was just telling me this most beautiful story of how initially she contacted me and she's like, I don't know about this gluten-free thing. I come from an Italian family and we've got generations of, recipes passed down. And then she just told me this beautiful story about 3 months later. She just completely messaged out of the blue of how her husband they'd supported this change towards going gluten-free. And I'm not going to tell the story now because I've got getting her on the show to talk about it, because I said, we need to hear from normal people too. Like, in your experience where you're at in your thyroid journey early on is very different to when I talk about me, and dietary changes, because I made them 10 years ago and now it's just normal. So all these different perspectives, so important.
Absolutely. Yeah. Same when it comes to the science. You can't dip it. Everybody can't jump into the deep end right away and go, oh, you got to start with some simple concepts, and whether they get that from my book, your book, or multiple books, you got to start with the simple concepts, and then build from there. But it's important stuff to learn. I mean, there's nothing important than your health and your well-being, and it's not too often you hear somebody that's not doing well who goes back and says, you know what, I'm so glad I didn't pay any attention to my health. Everybody
that's right.
When they're not doing well, they're like, I wish I would have taken more time to pay attention to what was going on with my health. So do it now.
Yeah.
Read Let's Talk
books.
Thyroid.
Get both our books.
Read Thyroid Debacle. And then give us some feedback.
Yeah. Excellent.
Right.
Awesome. Okay. Well, thank you. Thank you so much for watching this episode of Let's Talk Thyroid. I would love it if you enjoyed it, if you would hit subscribe and the bell. That would be really helpful. Even more helpful, actually, would be to share it with someone else who you know has thyroid issues or you think would benefit from listening. That really is part of my mission, I suppose, is to spread the message of positive and practical approach to managing your thyroid health so that people really kind of have more energy to get on with living their life and not just kind of trudging through each day. So spreading that word really genuinely helps other people feel better, live better, be better. The best way that you can connect with me is through my website, which is annabellebateman.com. From there, really, you'll be able to connect in all the other ways. I would love it if you would join my Facebook community group. There's lots of great support there. It's all free. That's just being with like-minded people. But from the website, you can also book a strategy session with me. So if you're feeling a bit overwhelmed, not too sure where to start, then book a strategy session. There's also freebies to download and links to look at my online courses or purchase some essential oils or my cookbook. So that's really the hub, would be annabellebateman.com. But look forward to connecting with you and just being in this thyroid health journey together. Have a great day. Bye.
The information presented and discussed in this podcast is not intended to diagnose, treat, cure, or prevent any disease and should not be used as a substitute for proper advice from a qualified professional.